all in US. And thank you, Jay, sir. Thank you, AIOS, for giving me this opportunity to be present and to present our case in this galaxy of luminaries meet. So the case is very simple, and it's a common case which we usually see in an OPD. So this is a case of a 59-year-old male which came to us, has been under treatment with us since many years. And known case of diabetes since last 15 years, hypertension 10 years, diagnosed as both eyes severe NPDR. In right eye, we did pars-plana vitrectomy for ERM and ILM peeling with IVTA for a little CME which he had, and that resolved after 2 years, and it resolved, and then it was stable since 2 years. And this is what the last follow-up before when he presented to us. And this is when the things turned a little downline. This is in June, what we can see on the left-hand side, where there is nothing on a superior temporal area, where there is a small hemorrhage. But suddenly in October, what we are seeing is a florid NVE clinically, which we could see, and there is recurrence of CME with hard exudates above it. When we did an OCTA, what we can see is there is noted areas of CNP, which is adjacent to it, proliferation, some kind of neovascularization which is around it, and as we can be seen in the superficial network and also in the NFAS. But when we saw the OCT-B scan, we could see that the flow signal was within the ILM, or it was in the superficial retinal layers and not above it. So we were not sure whether to call this as neovascularization or a florid IRMA, but still we considered, because it's too florid to consider as IRMA, we considered it is a neovascularization. And at that point of time, we could see that there was a little macular edema which also started. So we thought of doing an FA to understand what the reason is. So in this, most importantly, as we can see, the ART time was a little more, 20 seconds is what we could find out. And what we can see is this area adjacent is associated with CNPs, and it is arising from vein. If we can see in a very early stage, it is arising from a vein and not from an artery. And it's not showing very significant leak as what we see in a neovascularization, which is a florid leak, which we see. And this is similar in presentation of IRMAs in the other eye, which does not have any neovascularization, but some focal areas of leakages at the fovea. So the point of discussion at this point was that hallmark of PDR is a neovascularization that occurs at vitreoretinal interface. But in our case, is it an intraretinal neovascularization what we are seeing? Because the neovascular complex is seen in an FFA, OCT-B scan do not show the structures above ILM. And is it on an NFAS also, we can see there is a large area of network. And the B scan, OCT-B scan, which shows the flow signal, shows the flow signal which is below the ILM. In this case, we don't know what the reason is. The ART was a little high, so we got in to rule out ocular ischemic syndrome, but the carotid Doppler was normal. So we thought of treating, but within 1 week, the patient again came with us before giving the injection with high pressures and neovascularization of the iris. So at this point, we gave him all the anti-glaucoma medications and then started treating. And this is what the post-op looks like, or the post-treatment with anti-VEGF and laser. We can see all these florid areas of neovascularization has regressed, and only some loops are there in this two major vessels, or the venue or veins at that point. And this is again seen in an octa, where we can see whole network has resolved right now. This is after 4 months of treatment. NFAS image. And this is the OCT-B scan, which is the above B scan is showing the pre-treatment, where we can see the large area of network which was there below the ILM. And right now we can see that is resolved. So the questions to the panelists is this IRMA? Is this NV? Or is the IRMA which is transforming in the NV and which we have caught early? And why did the NV develop suddenly in this case? And is it an intraretinal neovascularization, and how common that is? And does the intraretinal neovascularization indicate to something very specific like this, where the patient developed NVG and NVI later on, and how to follow up this case? So these are certain references which I could find out. Then in OCTA, we can see that type 3 NV can develop from IRMAs, and again, which is close to that CNP areas, but it breaches through the ILM and then presents at NV, but initially it is like an IRMA. And these are two very old FFA cases where we can see similar presentation, where the CNP areas later on develop neovascularization, which they have considered intraretinal because it's not leaking, and once the treatment was done, it resolves. And these are two different case reports which show that. Thank you, and we are open for discussion. Thank you, sir.
Fendi.